Hello, and thank you for joining us for the 6th Annual Global Summit on Kidney Disease Innovations, Vox Populi. The time is now to prevent and cure kidney diseases. This summit is hosted by the American Association of Kidney Patients in partnership with our allies from the George Washington University School of Medicine and Health Sciences. My name is Jonathan Haydak, and I am an AAKP Ambassador from the state of New York. I am also a former dialysis patient and current kidney transplant recipient. I was diagnosed with a rare form of glomerulonephritis at 22 and began dialysis treatment shortly thereafter. My personal journey with kidney disease inspired a career shift, and I have been pursuing a PhD focused on kidney research at Mount Sinai in New York City since 2019. Being a part of AAKP since 2018 has allowed me to advocate for kidney patients at the congressional level, contribute the patient perspective to innovative research initiatives, and connect with other passionate individuals. More broadly, AAKP membership means being part of a collective effort to improve the lives of kidney patients everywhere. This year's Global Summit theme, Vox Populi, was purposely and strategically chosen by AAKP for its historical meaning, Voice of the People. I am one of the people who has chosen to raise my voice in support of greater care choice and innovation in kidney care. And I am one of the voices demanding a change in status quo kidney medicine. Over 850 million individuals across the world have kidney disease. This number is increasing at an estimated rate of 5 to 7% annually. Every year, we lose thousands of innocent lives to preventable kidney issues and the lack of timely access to treatment. AAKP believes kidney disease is both a workforce and healthcare issue. The disease takes a devastating toll on human lives and livelihoods. Most people understand that kidney disease, left undetected and untreated, can lead to premature death. But many are not aware that it impacts a person's dignity and ability to provide for themselves and their families. Kidney disease and outdated treatments can lead to unemployment, underemployment, disability, and dependency. In 2019, AAKP declared the next 10 years the decade of the kidney. The time is now for kidney patient consumers, healthcare professionals, researchers, industry, and all people of goodwill to unite our voices and demand change. We are optimistic we can and will save more lives. But to do this, we must demand new screening guidelines and diagnostics, new biologics, and new devices. Together, we can manage and solve this growing global public health crisis. The time is now for elected and appointed leaders worldwide to listen to patient voices. Governments must remove the regulatory and payment barriers they create that delay innovation and prevent timely care access. If governments fail to act, we must raise our voices and demand an end to negative government determinants of health. Make no mistake, every nation is impacted by kidney disease and millions of people are at risk. The optimistic news is that every person watching this program today can help those impacted by kidney disease and make an impact within their own nation. Through AAKP Global, AAKP is educating patients, care partners, healthcare professionals, and policy leaders across the world on unmet patient needs. Our annual Global Summit on Kidney Disease Innovations has helped put a human face on what is now the 10th leading cause of death based on data from the World Health Organization. We have connected people across the globe in a common purpose larger than any one person or nation. Together, we have increased hope and optimism. So thank you for joining us. Your voice is the voice of the people, and you can count on AAKP to keep amplifying it throughout the world to create change. With that, I am honored to serve as the moderator for our session entitled Research and Innovation to Prolong Kidney Allograft Survival. I am thrilled to introduce our next speaker, Dr. Fritz Diekmann. Dr. Diekmann is a consultant nephrologist at the Department of Nephrology and Kidney Transplantation at Hospital Clínic in Barcelona. He is heavily involved in the living donor kidney transplant program. Dr. Diekmann's main research interests include immunosuppressive strategies after kidney transplantation, particularly in expanded criteria donor kidney transplantation and hypersensitized kidney transplant patients. He is a member of many of the major nephrology and transplantation societies and currently serves as secretary of the European Kidney Transplant Association of the European Society for Transplantation. We're pleased to have Dr. Diekmann join us today from Spain. Doctor, I turn it over to you.
Thank you, Jonathan. Thank you, AAKP. And thank you, George Washington University, for inviting me and for having me here at this year's Global Summit. We're here today to talk about what it means to be a hypersensitized patient in kidney transplantation. These are my disclosures. So in patients with irreversible kidney failure, you have several options. Actually, we have three. You can replace the kidney function of the non-functioning own kidneys with a functioning kidney, which is a transplantation. You can replace, but only part of the function of the non-functioning kidneys, with dialysis. And you can do neither of the first or the second thing. The kidney transplant actually potentially offers a good quality of life, in the ideal case, an absolutely normal lifestyle, and for example, the ability to work, to travel, to have children, to build a house. However, there's more demand than offer of organs, which usually means there's a waiting list, and which means that part of the demand for organs needs to be covered by living donors. Not all offered organs from deceased donors are of optimal quality. And there's a further problem. Nature did not really plan for transplantation. And here you can see some Spanish figures where you have the green line would be the number of transplants, and the pink colored line would be the number of patients on the waiting list. So you see that there still is a gap between those two. Nature has other plans, and that's the immune system. The immune system is made up of a complex network of organs, cells, and proteins that fight infections, microbes, and protect from cancer, which allows us to live in a potentially hostile environment that's full of microbes, bacteria, viruses, for example. The immune system consists of white blood cells, antibodies, the complement system, the lymphatic system, the spleen, bone marrow, and thymus. Today I will only concentrate on the white blood cells and on the antibodies. The white blood cells are actually the key players in your immune system. They move through your blood and tissues, and they are always looking for foreign invaders, such as bacteria, viruses, parasites, fungi, and any other foreign biological material. Usually when they find any of this material, they launch an immune attack. The antibodies, a very important part of my talk today, they help actually the body to fight microbes. They do this by recognizing substances called antigens on the surface of the microbe. They mark the microbe that's foreign. The antibodies then mark these antigens for attack and destruction. And there are many cells, proteins, and that are chemically involved in this attack. So how does the immune system actually detect what is foreign and what is not? This is really important, because if the immune system could not differentiate between foreign and not foreign, then it might potentially destroy our own cells, our own body. And the immune system actually has the human leukocyte antigen system, which is kind of like a passport, consisting of a unique and personal mix of maybe bars, like in a barcode, and the barcode is expressed on all of the cells of our body. There are many bars that make up the barcode. The individual bars are quite often repeated in different individuals. However, the combination or the mix of the bars is almost always unique. If our white cells scan and detect our own barcode, it leaves the cell alone. It says, well, this is one of ours, that's fine. However, if it detects just one bar that is not part of the own code, it might mount an immune attack. And then we have an immunological memory. The immune system keeps a record of basically of every microbe it has ever defeated or ever recognized, actually, in certain types of white blood cells. We call them B lymphocytes and T lymphocytes, and these cells are known as memory cells. And this means it can recognize and destroy a microbe quickly if it enters the body again, before this microbe can multiply and make you feel sick or cause actually a disease. So the immune system is a highly sophisticated protection system. It is very efficient. it can develop a specific response even if the microbe so far has been unknown to the system in case of a first infection. And it can learn to perform better and quicker in the case of a second infection, like the immunological memory. And now we come to the transplant part. In case of a transplant, the immune system can actually turn into friendly fire because the transplanted organ, foreign biological material, normally will not destroy our body like a microbe could do. So, but the immune system could attack this tissue, and it can develop a first-time response to an organ with up to that moment unknown characteristics. It can develop a quicker, more aggressive response in case of a transplanted organ with characteristics that are already known or partially known to the immune system through the previous knowledge, the immunological memory. And this friendly fire is the main cause of long-term loss of transplanted organs. And thus the immune system can destroy an organ quickly in case of a very aggressive response. Usually, we do not have contact to tissue that is not ours. So how can characteristics of foreign tissue get to be known to the immune system? Through pregnancies, for example. The baby carries part of the genetic information of the father, so the mother during the pregnancy can get into contact with some characteristics of the immune system of the father or the baby. Through blood transfusions. Blood transfusions contain some cells, some lymphocytes, or through previous transplants. And through getting into contact with foreign tissue or characteristics of foreign tissues, we can develop antibodies. And these antibodies are an important part of our immunological memory. The antibodies can be identified. We can even measure their concentration. And up to a certain point, we can predict what will happen in case of a transplant according to the presence and the concentration of antibodies that can respond specifically to one or several of the barcodes of the donor. And we know that the presence of donor-specific antibodies worsens the outcome after transplantation and can lead to graft loss. And this is a slide from a scientific work where you see the survival curves of the graft survival curves according to the status of having a donor-specific antibody, DSA, or of not having it. If you're DSA negative, if you don't have a donor-specific antibody, then statistically you would be in the upper black curve. If you do have at least one donor-specific antibody, then statistically you would be in the green curve. So long-term, a lower graft survival. Of course, the best thing is to avoid a transplant with an organ whose antigens are already known to the recipient's immune system. That reduces the number of suitable organs among all the offered organs to a small percentage if you already have donor-specific antibodies. And sometimes this would mean that you have to avoid virtually all available donor organs. But that basically would mean that you might have to stay on the transplant list forever. So if you see all these potential donors as those person icons, maybe only one of them would fit you as a potential donor. And sometimes we have out of 100 potential donors, there's only one that would fit, or sometimes out of 1,000 donors, there's only one that would fit. So you can imagine that this makes a transplant without any donor-specific antibodies sometimes virtually impossible. So what can we do? We can give priority to patients with many preformed antibodies at the time of organ distribution, of organ allocation. This could be done through programs for hypersensitized patients, acceptable mismatch program, which are usually national programs or regional programs that give priority to those patients who have many antibodies. Another way would be finding a suitable donor through a paired exchange program in case of an available living donor. If your direct living donor is not compatible, then through a paired exchange program, you might find a compatible living donor. Or in some cases, you can remove the antibodies from the body and prevent the body from producing new antibodies. This, although, has its limits because the immune system has been trained over millions of years and is able to react, including to these measures. If you remove the antibodies, you use antibody removal techniques. One could be called plasma exchange. You might have heard of that. Another one could be called immune absorption, and there are other techniques of antibody removal. The problems of the antibody removal are that you leave the body temporarily with less capacity of defense, because we usually need our antibodies in order to defend us from certain infections. Since the immune system has a memory, it produces the same antibodies again in a very short period of time, and this could be hours. And therefore, in a case of a planned or already performed transplant with donor-specific antibodies, we not only have to remove these antibodies, but we also have to give treatments that actually inhibit the body's capacity to produce new antibodies. Having many HLA antibodies, which is basically being hypersensitized, means that you have less access to suitable kidney donors compared with patients without any antibodies. Thus, your waiting time usually is a lot longer. Your immunosuppressive treatments will most likely be more aggressive. And if you receive a transplant, the graft will most likely last less long compared with a person without antibodies. However, you still have a benefit from a transplant compared with remaining on dialysis. So what can we do? I think in this situation, we have to reanalyze the risk-benefit balance, and we have to have a closer look at the relative risk associated with remaining on dialysis and compare this with the risk associated with a more aggressive immunosuppressive therapy and the risk that is associated with a shorter graft survival, but that could still be lower than the risk of remaining on dialysis. In that sense, we have to work on new strategies of organ distribution and on new treatments, improving the access and reducing the risk associated with aggressive treatments. And at the same time, we have to improve our prevention strategies for chronic kidney disease and improving dialysis, because the ideal thing would be not needing a transplant and not needing dialysis. So we can conclude actually that the human body is protected by a highly effective immune system in order to be able to live in an environment full of infectious agents. In case of a transplant, the immune system can mount a response that is directed against the transplanted organ, and that is, of course, that the organ is already part of the recipient, and this could be called somehow friendly fire. This friendly fire is more fierce and more aggressive. The transplant carries characteristics that are already stored in the immunological memory. Since the immune system is difficult to fool, theoretically, it is always better to avoid characteristics that are already known to the recipient's immune system. However, in many cases, the recipient's immune system is already so well trained that it knows at least one characteristic of the organs that are potentially offered. And therefore, in those cases, special organ distribution strategies and therapies might be necessary to delete or attenuate the immunological memory. And this could be antibody removal and special immunosuppressive treatments. And with that, I would like to thank you for your attention.
Thank you, Dr. Diekmann, for your informative presentation. I have a few questions I'd like to ask you. Number one, can you tell us how your engagement with patients has helped you better understand the obstacles that must be overcome when using immunosuppressive therapy for kidney transplants?
Well, the interaction with the patients is very important in order to understand their point of view. I might have an idea of what the treatments mean. I might have an idea of what the situation with the patient or the patient situation might be like, but it is of utmost importance actually to listen to the patient and to get his or her point of view in order to propose, explain, and discuss therapies. Otherwise, my proposals might just not be adequate.
What has science shown you regarding the tactics being used to increase the success rates of ECD kidneys, and are the tactics working in the way you would hope?
Well, ECD kidneys are kidneys actually that can give good results, but that usually give not as good results as standard criteria kidneys would give. However, if the alternative is getting no kidney and remaining on dialysis, then the ECD kidneys can still give you some very good results. Over the time, we've learned to get the most out of these kidneys, as we've learned to get the most out of any kidney, using special techniques in order to assess the quality of those kidneys. We might also do some ex vivo manipulation of those kidneys in order to assess the quality and in order to improve those kidneys. And over the last 30 years, actually, we have learned to use those kidneys, how to use them better. And I hope that in the future, there will be more advances in order to even use those kidneys better.
Is there any evidence of promising new therapies for managing sensitive patients before and after receiving new organs?
Okay, sensitive patients in the meaning of patients who have many HLA antibodies. There are some new promising therapies that help actually to reduce the concentration and the amount of antibodies at the time of transplantation. One of them would be imlifidase, and there are different strategies that actually help us to maintain those antibodies low or in a very reduced state, so that they cannot actually harm the transplanted organ or to reduce the potential harm. And those are different strategies, and in the last 4 or 5 years, we've seen major advances in that field.
And lastly, the theme of our global summit is Vox Populi, and kidney patients, including transplant patients, are demanding improvements in kidney care. Can you tell our audience what research projects you are aware of that will increase hope and enhance immunosuppressive techniques for kidney transplant patients?
There are several initiatives and research projects for the hypersensitized patients, different projects actually that improve the access to kidney transplantation for those patients with the use of imlifidase, with the use of other medications such as anti-CD38 antibodies, for example, would actually improve the access of those patients who are waiting for a long time for a kidney transplant. And I think those are the most promising ones right now.
Again, thank you, Dr. Diekmann, for your engaging presentation.